Hello, my name is James Lasky, and I would like to introduce a very special guest and friend, Dr. David Armstrong. Well, welcome to another episode in our three-part series presented by Rehabtronics on pressure injuries. The topic of this episode is, what do we know about pressure injuries, why they form, and who is at risk? In one of the other episodes where we talked about what is and what isn't a pressure injury, we certainly covered some of this. It's very hard, I know, to kind of separate these topics because they're all interrelated, but we're going to really focus on what we know about pressure injuries, why they form, who's at risk. And the objective of this episode is to explore some of the newer research on pressure injury formation, and you hit on some of that already, Dr. Armstrong, with a particular focus on the issues of tissue perfusion and ischemic injury. And we're going to examine, and maybe a little more deeply, some of the risk factors and comorbidities that put patients at risk related to that. So could you, for the people maybe haven't watched our other sessions, or for those of them maybe watched it a little while ago, could you just recap briefly sort of what is and what isn't a pressure injury, just briefly?
Yeah, sure. So a pressure injury is caused by low pressure generally speaking, by low pressure over an extended period of time. Often it's over a bony prominence, but it's that low pressure over a prolonged period of time. That, when combined with the lack of or some diminution of sensation, also diminution of function, so you can't move out of the way to stop the problem potentially, or along with some degree of ischemia or vascular disease, puts someone at significantly greater risk for developing that pressure injury. And it's something that costs anywhere between $20 and $30 billion in the United States alone. It kills more people, unfortunately, than auto accidents now in the United States.
Okay, thanks for that. So can you tell us a little bit about me, and again, since you sit on the NPIAP, so you have access to a lot of the current thoughts that, what's coming out, that what's new and novel. Can you tell us a little bit about the current thoughts about mechanism of injury, some of the specifics? We know that, as you've described, it's related to pressure, sensation, circulation, mobility, but maybe a little bit deeper for some of us who are really interested in pressure injuries, and we'd like to know, sort of have a more of a deep dive on what is the mechanism of injury that is you currently thought of.
Yeah, well, I think that as we get better in modeling this area, and there are a host of engineers that are doing really awesome work in modeling these sorts of things, we can identify sort of at a very using finite element analysis, or much more sophisticated than that, even just some stick slip kind of intervals, almost like a tent pole sort of issue, versus sticking into an area versus one that wouldn't. Is a method of identifying kind of stick versus slip. And the identification of this, and then the prediction of this early on with really more sophisticated modeling, both on the physical side, but then also looking at certain types of tissue analytes, things like subepidermal moisture content. There have been abundant data to support that. It's just getting stronger and stronger, looking at other aspects of pre-ulcerative inflammation that might exist around an area, if not in the center of it, looking for issues that might show an asymmetry in inflammatory targets. Also using other types of imaging like hyperspectral imaging that might also show asymmetries in the microcirculation that could predict the onset of injury, and then maybe allow someone to intervene a bit earlier. All of that, I think, is very, very exciting. I'm the principal investigator for a program called the National Science Foundation's Center to Stream Healthcare in Place at USC, but we have University of Arizona, our sister school at Caltech, and University or Baylor College of Medicine, University of Missouri, and University of North Dakota, as well as UNC, that are coming on board. And all of them are working on a whole bunch of other sorts of really cool new tools to try to extend what we call hospital-free days and activity-rich days. And there's stuff going on now in what we call epidermal electronics, which is an entire field now. One of my friends who's an engineer not too far from us, just up the road in Caltech, Wei Gao, is working on that. But imagine a little patch that you could place in an area that could, and you don't even have to imagine this anymore, that could identify some of the things that I'd already mentioned in real time, and then communicate that through like a Bluetooth radio or another kind of radio to either someone's phone or to a kind of a home or to a monitoring system. All of this is very, very real and is showing significant promise. But then, look at the potential then to intervene with a patch on that area, and then maybe even to have a super cool kind of closed loop system. It's all there.
Has there been any sort of in the last number of years, any sort of advances in our understanding sort of at the more microscopic level, cellular level, about the mechanism of actual injury? Like what is actually happening?
What we're likely seeing in this and in other kinds of tissue injury, maybe a little mini ischemia reperfusion injuries. And so that is fascinating because it may be changing the way we're thinking about how other types of wounds develop as well. I don't want to go off the subject too much, but in diabetic foot ulcers, we used to think that it was just repetitive stress that was causing most of these wounds to occur. And that's probably true. But in fact, what we're finding is that unprotected standing in those patients with diabetes can actually put them at higher risk. So we say sitting is the new smoking. Well, if you don't have sensation, then standing can be dangerous too if you're not kind of moving effectively. So all of this may be increasing someone's risk for developing these sorts of complications and doing it in a manner that is really kind of quiet, kind of sotto voce, if you will. And that is doubly sort of sinister, is sort of what we're seeing. And the other thing, by the way,
go ahead. Sorry.
Forgive me. We had mentioned the subepidermal moisture content, but looking at the viscoelastic qualities of tissue, many people who are at risk for getting a pressure injury may have diabetes, and diabetes, along with other kinds of problems, can make your skin, because of changes in moisture content and sweating and other things, can make your skin a little more like a cracker and a little less like a kind of what's a culinary analogy? Like a tortilla. I think a tortilla is probably better than a cracker. And so that can also make things more friable and more likely to break down as well. This is why people get retinopathy and nephropathy and even neuropathy, the small vessel disease. And that is likely playing a role in the skin, but also in the little intercellular kind of connections and communications as well, when we're starting to see just more friability, as it were, less functional reserve. Right.
Yeah, and it seems like, sort of like a lay person, maybe if we would just do a little one of those like Conan O'Brien or late night show, question people on the street about like what's the one thing to do to prevent pressure injury, they would all, people on the street might say, hopefully they would say, oh, well, you just have to change position every 2 hours and you'll be fine. And we know that that's almost like the bread and butter is position and changing. But I think part of it is also, one, like you're saying, when patient care gets crazy and it's hard to keep track of things. So not to be critical of any of the patient care, but there may be other issues, or they have to stay prone. Like, sorry, I mean, they gotta breathe. So get up, okay, that's what we're gonna do. It's kind of like when I worked with in trauma ICU with new brain injuries. Like, you know what? We'd love to put them in a different position because they're getting pneumonia, but their head has to stay up. Their high intracranial pressure is dying brain cells, so their head is up, and too bad for their lower lobes. We'll deal with that later. So we have this bread and butter of the reposition every 2 hours, whether it's in ICU, on the ward, at home, for anyone who is at risk. And so we think about that. Just it seems like we've saturated the kind of basic things, if we could at least follow and I want to turn the statement you talked about earlier from your colleague in England. I think that'd be a great bumper sticker. We could give that to all our graduates. Sort of just like do what we already know, like if we just did that. But anyways, so I think this is a good place to, again, we're gonna talk about emerging tech in a moment, but I think this is a place to talk about prolivia, and one of the issues related to prevention of pressure injuries for, whether people are being turned or not for whatever reason, would be looking at perfusion. And so could you just share again, just a little teaser about prolivia and how in the intensive care setting, in the critical care setting, this doesn't take the place of a person being repositioned as needed and all those other things that we would do, but how could this add to the tool belt for healthcare, physicians, nurses, therapists to help prevent pressure injuries?
Yeah, so this specific technology could be a potentially really important adjunct. And it certainly stands to reason that it would. And what it is, just very briefly, is imagine just a patch or a series of patches that go on or around the area at risk or concern, and then those patches can then deliver just an kind of an intermittent electrical stimulation, and that leads to brief, almost imperceptible muscle contractions right around the area, and that micro movement is enough to deliver and improve microcirculation in an area, and it's really quite profound. And in doing that, one can potentially reduce the risk for developing pressure injury in that area. This is the idea, and this is the additional sort of set of hands, if you will, on a service that might be able to improve care.
Yeah, I think if I remember my numbers right, in reading some of the preliminary studies that have been done with prolivia, that given that it is providing with this electrical stimulation periodic, it's helping to maintain blood circulation and blood oxygenation, which is critical, tissue oxygenation. And I think if I remember correctly, it was about increasing blood oxygenation compared to without it being on about 28%. So increasing oxygenation to, you're helping mitigate the ischemia, which may, we would hope protect the tissue. Doesn't take away from the other things that we must be doing to prevent pressure injuries in any setting.
Yeah, and there you go. I think that's kind of the big idea.
Great. Okay. Well, thank you so much for talking to me in this episode, talking a little more deeper in terms of what do we know about pressure injury, some of the sort of the epidemiological issues related and numbers related to pressure injury, some of the histochemical and issues related to the tissue specifically, and also really teasing for our episode on emerging tech. I think I'm holding you back from talking about all of that. I keep saying stop. So we'll jump onto that in the next episode. Thank you very much, Dr. Armstrong.
Total pleasure.